Good evening, and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member in the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus, and a family physician at the Gateway Family Health Clinic in Moose Lake, Minnesota. I'm your host for tonight's program on end of life and advanced care planning. The success of this program is very, very dependent on you, our viewers. Please call in or email your questions, and we will do our best to address them. The telephone numbers and email addresses for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Jeff Copeman, a family medicine physician with the Fairview Mesaba Clinic in Hibbing, and Dr. Amy Greminger, faculty member at the University of Minnesota Medical School Duluth campus and internal medicine physician at Essentia Health. Members of the WDSE staff are standing by to take your calls. And now on to tonight's program. Welcome, both of you. This is really a good program. As I was prepping a little bit, I was thinking about why our interest gets to where we are. Amy, what's your interest and what leads you to an interest in advanced care planning?
Absolutely. I think that's I know it's always a kind of a conversation killer when I'm at parties. I'm like, I work in hospice and palliative care, and people get quiet. But honestly, it's a really affirming choice in a profession to be able to be with patients, to help understand what they want for themselves, to help them understand what their choices are, and then to help give them their choices and to implement things like that for them. It's a really special time and such an honor to be able to participate in that kind of care.
Dr. Copeman, the same question. You've had an interest, we've had you on here many times for this show, and this is one that you appreciate.
Yes.
and enjoy coming to. What stimulates your interest in this?
Well, like Amy, I have an interest in end-of-life care, in geriatrics, and advanced care planning is probably one of the most important things that we do, even in my practice as primary care. Advanced care planning is something that is, I guess the best way to put it is that we need to know what patients' wishes are at end of life, and it's very, very complicated. Now with physicians' orders, with living wills, et cetera, now is the time when patients are able to make that decision to get it in writing. In my practice, I've seen families absolutely torn apart if there was not advanced directives in place when a family member becomes very, very sick and others are forced to make decisions for them.
Dr. Greminger, maybe if you could capsulize that and just give me a little bit more on what advanced care planning is.
Absolutely. So advanced care planning is a conversation. It's not necessarily always a destination. And so what it is having a guided conversation with people, thinking about what your values are, what your goals are, what kinds of trade-offs you're willing to make, what kinds of things are unacceptable for you, and who might be a good or helpful resource if you weren't able to speak for yourself. And so those conversations that we have, you usually start kind of talking to patients about these ideas, clarifying and getting some clarity on what those are, and then we help them write down what their goals are so that the family isn't left wondering, I wonder what my loved one would have wanted, and the family can really help us understand what the patient's wishes are.
Jeff, when should that begin?
Personally, I think that should begin early, not just when you're diagnosed with a terminal illness or a chronic illness, because things can change over time. You can be in a car accident in your 40s and be in a coma and be in the ICU, and if there's no advanced directives in place, once again, that burden can be pushed on the family. I always recommend to patients, at least in their 40s and 50s, to start going through it. They can be updated as needed. Most people will update their advanced directives about every 10 years.
Amy, how do you do this? Do you, is this, we're in doctor-patient relationships all the time, and that's very private. Is that how you do that, or do you expand, or is it, what's your process?
Yeah, so I think a lot of times it is physicians that kind of open up that discussion to people. one of the reasons I'm really excited that we're having this conversation is COVID has changed a lot of things for a lot of people. And even though we don't expect young people to necessarily to have those life-threatening illnesses, this last year has let us all really realize how fragile life is and how unexpected things can happen. And so I think a lot of times physicians will kind of open up the door to patients to ask if that's something that they're interested in, but it's not necessarily just physicians who are able to have those conversations. A lot of times nurses who are well trained can also have those conversations with patients, and it's understanding if people are interested in it and helping them get to a place where they can have a good conversation about that.
Jeff, when you do this, do you bring other members of the family into this? How do you handle that piece?
Mm-hmm. It depends on the context in which we're seeing the patient. A lot of times we'll review that at their annual examination with just the patient, but when somebody is diagnosed with a terminal illness or is very sick, we will involve the family too when we start doing the actual paperwork, because it's a family issue. Even though the patient makes the decisions, it's a family decision.
I love that idea, Dr. Copeman. I think one of the most helpful things, one of the things that we're hoping will come out of advanced care planning often is, if you were unable to make the decisions for yourself, who would you want there to make the decisions? But it's most helpful if that person who you would want to make the decisions for you can be there and present for that conversation, to hear that discussion of the goals and the values, because it can be really clarifying for them to understand kind of what that patient's goals or values are. So I think it's really helpful to have the decision maker involved if that's possible.
Mm-hmm.
I think of the disasters that I've walked into where families are dispersed and somebody hasn't been around for a long time.
Mm-hmm.
And I've worked through with the patient and with the local family where we're at, and then someone comes in from outside with other thoughts. So this kind of planning helps cement and avoid the disasters that can happen from that. Very much so.
Absolutely, and I think it leads to more conversations, right? Sometimes I've been in situations where a person has named a surrogate decision maker, and then the person that they named is surprised that that's the person that they named, or maybe there are other family members that are surprised. You know, you picked this child and not that child, and how is that? Why is that? And I think that having that conversation and really being open about those helps to prevent some of those surprises from happening later on, and that is really a gift to the family in general, so that there's enough stress when people are going through life-threatening illnesses that they don't need to navigate that additional surprise stress.
COVID has been an interesting pandemic in so many ways. So as you've both dealt with this with advanced planning, advanced care planning, has COVID challenged that in any way? This was not something that anybody probably foresaw as they did their planning, and now they've got COVID. Does that change? How do you handle the situation like that?
I would have to say that COVID has spurned a lot of advanced care planning discussions, because COVID has been so unpredictable for the most part. One of the things is that we can't really predict who's going to get the severe illness. It can be anyone in their 20s or anyone in their 80s, and so this, because of the nature of the pandemic, it's spurned a lot of advanced care planning discussions.
One of the questions that's come in is, what about children? Should you be thinking about advanced care planning for your children as their caretakers?
You know, I think I always encourage people to start early, and so I think, you know, I teach younger people. I don't teach 18-year-olds, but I teach people in their 20s, and I think that even thinking about this as a younger person can be really helpful. With children less than 18, I think that if, it's not necessarily expected. You would hope as a family you would know kind of what their wishes would be, but not always. And so certainly if there was a child that had a serious illness, I think it would be very helpful to talk about some of those things together as a family. But there are wonderful people and resources a lot of times that can help with children with serious illness that can help foster good conversations around that. People like child life specialists that are employed by a lot of the hospital systems.
I echo that. If the child has a serious illness, absolutely advanced care directives should be discussed with the family.
How do you incorporate the child into that?
A lot of it is age dependent, to be honest with you. And depending on what the terminal illness is. If someone has cerebral palsy and has limited capacity, and we can talk about the difference between competency and capacity to make decisions, that will affect that.
Well, you brought it up, so
Yep.
separate these two
Sure,
for me.
I will. When we look at advanced care planning, one of the most important things is we want to know if the patient has the capability of making those decisions for themselves. That's what's called capacity. That means you're able to do that. Patients with dementia can make decisions regarding their health if their level of dementia is where they still have the insight and the understanding of their illness and the consequences of treatment or no treatment. So that's what capacity is. Competency is a legal term. And what we mean by competent is that there may be patients who have chronic illness, terminal illness, that may have advanced dementia, and they do not have the insight to make those decisions for themselves. And so in that case, the judge can deem that patient incompetent to make those decisions for themselves, therefore others do it for them.
There are situations where there are spiritual differences in the parents as to the care given. How should that be handled if you're your primary care family doc? How do you handle that situation?
To be honest with you, that has come up, and the most important thing is about the patient. It all depends on the age of the patient and if they have the capacity to make decisions. Still, it's the patient's decision. If they're underage and their parents are their guardians, that brings up a whole different issue.
Okay, we'll switch gears just a little bit. Great discussion. Amy, what percentage of the population does advanced planning?
I am not sure on the exact percentage. I think it really varies by communities. There are certain communities, for instance, La Crosse, Wisconsin, I know has a really strong and robust community system where I think in that community, I want to say 90% of people have filled them out. In other communities, it's going to vary quite a bit from that. What I can say is I do think it's an important thing to think about, again, for many reasons, but especially in the pandemic. I think being prepared to have somebody that would really know what you want is just so helpful.
Is there a stigma? Oh, excuse me, go ahead.
Yeah, I was just going to say, in our practice, I think the amount of people doing advanced directives is actually increasing. I think because as much as some of us are not big fans of the electronic medical record, it makes it does make it a lot easier because all the things that we want to talk about are right there in front of us as practitioners. The other thing that is when patients are coming in for their annual exams or for routine exams, that's part of our intake. Is there advanced care planning on file, and would you like to discuss it? Particularly those over age 65 that are in for their Medicare wellness. So I would have to say that it's increasing. I don't know the exact numbers where I practice, but it's increasing.
So let's go down a different road. We have POLST, P-O-L-S-T. We have advanced care planning. I think in POLST there's something about CPR and other types of care. And in other states, not this state, that can go all the way on to possibly assistance with terminating a bad situation in this person's life. Amy.
So I think that is a great thing. There's a lot of unique vocabulary around these discussions. So advanced care planning is something that anybody can do at any point in time. A POLST is a physician order for life-sustaining treatment. And so those are actually, it's different than advanced care planning in that advanced care planning is more of a conversation. A POLST is actually physician orders. And so typically those are filled out for people that have documented very serious life-threatening illness. They typically are in the last 1 to 2 years of their life. And so oftentimes people that are in nursing facilities will have those filled out, or people that have serious illness. So that can be a distinction. The other thing I just kind of wanted to throw in a side comment. One thing you had mentioned stigma earlier. One thing that sometimes I hear is, well, what if I change my mind, or can I change my mind? And what I would say is, people can always change their mind at any point in time. This isn't a destination, it's a journey. It's trying to document what you want at that point in time. And so a lot of times what we'll do, especially if somebody has started planning younger, is we'll recommend updating these things about every 10 years or so. Because people's goals change.
As a caveat, I might explain as to why the POLST even came about. It's a relatively new thing. As Amy said, POLST stands for Physician's Orders for Life-Sustaining Treatment. That's different than a DNR/DNI, and it's different than a living will. The reason that Minnesota actually is one of the first states that actually addressed this is that if somebody has a catastrophic illness, they're required to do CPR should the ambulance come until they have a physician's order. So it doesn't matter if you're a DNR, what's quoted as a DNR/DNI, if they come to your house, they have to do it until they get a physician's order to not resuscitate or to do anything like that. And so the problem with that is when you look at cost and you look at other things that come up with that, is that we wanted to be able to have that order written so that when an emergency personnel comes to your place or your facility, the order is signed by the physician and is there documenting what your wishes are. In that case, they do not have to begin CPR if that's there.
Is where?
We have it, we make sure that it's in the refrigerator or with the patient. We also scan it into their medical record. And in our area, we use pretty much the same one, even in Duluth. And so that's in there. And so they can click on it and see that it's there.
I'm out of date. Can you access the EMR in the ambulance?
That, it depends on if you have rights to do that. We can do it on our cell phones. So it's best to have it on the fridge, different color, so that when they come in there, they can look, or they'll ask the family members, is there a POLST?
I wanted to mention one other thing. You mentioned death with dignity. I would say that is a separate, again, this comes with its own unique set of vocabulary and descriptions. So advanced care planning is one thing. A POLST is another thing. Death with dignity specifically addresses physician aid in dying, and it's not currently legal in Minnesota. It is legal, I think, in 11 states or jurisdictions at this point in time. Most famously Oregon, but also California, Washington, Colorado, and several other states. But again, not legal in Minnesota at this point in time.
Yes, and right now, because we get that in our world of hospice and palliative medicine, we will get that request saying, I know I'm terminal, I'm in a lot of pain, why don't you just give me enough to let me die? But it's not legal here.
I can see the eyes of a woman, give me the shot.
Yeah.
And those are tough.
Very tough.
So do you want to talk about honoring choices and the website, just briefly, so we don't forget it?
Sure. Honoring choices it's a very well-written and I think detailed discussion of advanced care planning, and it's got certain parts in it that includes a DNR/DNI, some of the other wishes that are part of a POLST, all in one form. And they have a website, and you're able to go in and read through that. You can download things. In my practice, when I have advanced care discussions, I will give them a copy of Honoring Choices to take home and go through with their family members.
And I see it's at the bottom of the screen, so thanks for putting that up, WDSC. Are there other resources that people can go to start this conversation with a loved one, or is that the best resource?
I personally use that almost exclusively because I think it's very well written, it's very thorough, and covers pretty much everything, and then the patients will come back and we'll go through it in detail.
I think it's a good website as well. I would say that a lot of different things tend to spark conversation on this. You know, I think for some people, go to this website can be intimidating. Sometimes it comes up naturally with books that people might read, or conversation talking about COVID can be an open doors to talking about this. So it can come up through other means as well. One of my favorite books that a lot of times people ask me if I've read is called Being Mortal by Atul Gawande, which really talks about a lot of these issues.
I just wanted to touch on one thing. There's one of the most common questions that comes up in our practice, and I know Amy sees that too. What does it mean to be DNR, DNI? Mm-hmm. What does that mean?
Yeah, what does that mean?
And so, the concept in the public varies. Some will interpret that as being, well, you're not going to do anything. That means if I sign this DNR, DNI, that means you're going to put me out to pasture and just let me go. And actually, nothing could be further from the truth. What DNR means do not resuscitate, DNI means do not intubate, that's life support systems. Basically, the one thing we have to remember is that your heart has stopped. That's where that takes effect. And so that doesn't mean we don't do treatment. That doesn't mean we don't put you in the ICU. That doesn't mean we don't admit you to the hospital. We treat everything. It's if your heart stops, we don't do anything to start it again. And that's a very common misconception that the public has.
There was a great article, I forgot where, but it showed the expectations of the public and the expectations of our profession for DNR, DNI, resuscitation, and the rest, and how many would or would not do that, which is an interesting discussion. Mm-hmm. I believe something like 40% of the people survive on the shows.
Oh, yeah.
Yeah. And in real life, depending on where you are, I think in hospital resuscitations, it's something around 20% survival to end hospitalizations. But if you have a serious life-threatening illness, and that includes dementia or cancer or really serious heart failure, the chances of surviving to exit the hospital oftentimes are less than 1%. And that really does move where a lot of people want to be, kind of knowing the odds. And it a lot of times is very different than what people see on TV or what people might expect.
Jeff, a Hibbing call. Is there a difference between advanced care planning and power of attorney?
Yes, and if I might explain that, advanced care planning is a global thing which includes a lot of different parts. That includes the DNR, DNI, that includes something called the living will, that includes power of attorney. All that is part of Honoring Choices. But if I might explain what that is what a power of attorney is. It's not the power of attorney for finances. We're talking about the power of attorney for making medical decisions, and that's someone that you designate, or by law, if you're not able to make that decision, the next of kin makes those decisions for you. So that's what a power of attorney is, and it's something called a durable power of attorney of healthcare that we go through.
Amy, can you clarify the difference between healthcare directive and POST? Question to you.
Absolutely. So I would say that healthcare directive is kind of that bigger conversation about who might help out with healthcare decisions, what are your goals, wishes, what would you want in case of a catastrophic illness. It's that bigger kind of conversation and that clarification. A POST is a very specific form that is for people in the last 1 to 2 years of their life, and those are actually physician orders that say if somebody's heart stops, this is what they want us to do. And the answer could be to do CPR, or it could be to not do CPR. It doesn't necessarily say what the answer is. It's just the form that talks about what the questions are.
Jeff, a 30-second question. Is there a difference between or a stigma around advanced care planning? Is there a stigma around advanced care planning?
I would have to say that sometimes when you bring up the conversation of advanced care planning, there can be a stigma because they're saying, what do you mean? Am I dying? Am I very, very sick? And a lot of times that isn't the case at all. We're trying to just make plans for if something should happen. So yeah, I think there's a little bit of a stigma around that.
What a great evening. Just Amy and Jeff, thank you so much for coming in. I want to thank our panelists, Dr. Jeff Copeman and Dr. Amy Greminger, and their WDSE phone volunteers. Please join Dr. Peter Nalen next week for a program on allergies, asthma, COPD, and lung problems, when his panelists will be Dr. Wayne Elmer and Dr. Jason Wall. Thank you so much for watching. Have a great evening.